Define nephrotic syndrome. Nephrotic syndrome is the combination of nephrotic range proteinuria with a low serum albumin level and edema. What is nephrotic range proteinuria? Nephrotic range proteinuria is the loss of 3 grams or more per day of protein into the urine or, on a single spot urine collection, the presence of 2 grams of protein per gram of urine. Creatinine, incidence 2 to 7 cases per 1 lakh children per year. Higher in underdeveloped countries, Southeast Asia. Occurs at all ages but is most prevalent in children between the ages 1.5 years to 6 years. It affects more boys than girls, 2-to-1 ratio. Classification of nephrotic syndrome. Nephrotic syndrome can be primary, being a disease specific to the kidneys. Or it can be secondary, being a renal manifestation of a systemic general illness. Etiology. Primary causes of nephrotic syndrome include the following, in approximate order of frequency. Minimal change nephropathy, focal glomerulosclerosis, membranous nephropathy, hereditary nephropathies. Secondary causes include the following, again in order of approximate frequency. Diabetes mellitus, lupus erythematosus, viral infections, EG, hepatitis B, hepatitis C, human immunodeficiency virus, HIV, amyloidosis and paraproteinemias, preeclampsia, alloantibodies from enzyme replacement therapy.
The pathogenesis is not fully understood. There may be a metabolic, biochemical, physiochemical, or immune-mediated disturbance that causes the basement membrane of the glomeruli to become increasingly permeable to protein, but the cause and mechanisms are only speculative. The glomerular membrane, normally impermeable to albumin and other proteins, becomes permeable to proteins, especially albumin, that leak through the membrane and are lost in urine. Hyperalbuminuria. This reduces the serum albumin level, hyperalbuminemia, decreasing the colloidal osmotic pressure in the capillaries. As a result, the vascular hydrostatic pressure exceeds the pull of the colloidal osmotic pressure, causing fluid to accumulate in the interstitial spaces, edema, and body cavities, particularly in the abdominal cavity, ascites. The shift of fluid from the plasma to the interstitial spaces reduces the vascular fluid volume, hypovolemia, which in turn stimulates the renin-angiotensin system and the secretion of antidiuretic hormone and aldosterone. Tubular reabsorption of sodium and water is increased in an attempt to increase intravascular volume. Clinical manifestations of nephrotic syndrome appears first in areas of low tissue resistance. Example: the periorbital, scrotal, and labial regions. It can progress rapidly or slowly. Ultimately, it becomes generalized and can be massive, called Nephrotic. The edema is pitting and typically dependent, being more noticeable in the face in the morning and predominantly in the lower extremities later in the day. Children with nephrotic syndrome occasionally present with gross hematuria. Urine looks dark and frothy. Anorexia, irritability, fatigue, abdominal discomfort, and diarrhea are common. Gastrointestinal distress can be caused by ascites, bowel wall edema, or both. Respiratory distress can occur, due to either massive ascites and thoracic compression or frank pulmonary edema and effusions, or both. Diagnostic evaluation. Urinalysis. Urine protein quantification, by first morning urine protein creatinine ratio or 24-hour urine protein measurement. Serum albumin. Lipid panel. Complete blood cell, CBC, count. Metabolic panel, serum electrolytes, blood urea nitrogen and creatinine, calcium, phosphorus, and ionized calcium levels. testing for human immunodeficiency virus, HIV, hepatitis B and C viruses. Complement studies, C3, C4. Anti-nuclear antibody, ANA, anti-double-stranded DNA antibody, anti-neutrophil cytoplasmic antibodies, in selected patients. Other tests and procedures in selected patients may include the following: genetics studies, kidney ultrasonography, chest radiography, MAN2 test, kidney biopsy, age less than 1 year or greater than 12 years, or other circumstances, management of nephrotic syndrome. Objectives of therapeutic management: 1. Reducing excretion of urinary protein. 2. Reducing fluid retention in the tissue. 3. Preventing infection. 4. Minimizing complications related to therapies. Management. Initial episode. High protein diet. Salt moderation. Treatment of infections. If significant edema, diuretics, aldosterone antagonist, furosemide, spironolactone. Corticosteroid therapy with prednisolone or prednisone. 2 mg per kg per day for 6 weeks, followed by 1.5 mg per kg single morning dose on alternate days for 6 weeks. Relapse. Infrequent relapses, 3 or less relapses per year. Frequent relapses, 4 or more relapses per year. Frequent relapses and steroid dependence children need. Long-term alternate-day prednisolone. Steroid-sparing agents like levmisole, cyclophosphamide, mycophenolate mofetil. Diet modifications. Energy, at least the recommended dietary allowances for desirable body weight. Protein, RDA for age, with special attention not to replace urinary protein loss and to keep protein within 0.7 to 1.0 grams per kg dry or ideal body weight. Sodium, restrict when edema present and limit to 2000 milligrams per day. Fluid, restrictions based on the desired effects of diuretics. Vitamins, insufficient amounts of calcium and B12 in the modified diet necessitate a daily calcium supplement and NVI with minerals. Complications: 1. Hypovolemia. 2. Thromboembolic complications, renal vein thrombosis, venous and arterial thrombosis in extremities, pulmonary embolism, coronary artery thrombosis, cerebral artery thrombosis. 3. Altered drug metabolism due to decrease in plasma proteins. 4. Progression to end-stage renal failure. Monitoring fluid intake and output. Accurately monitor and document intake and output. Weigh the child at the same time every day, on the same scale in the same clothing. Measure the child's abdomen daily at the level of the umbilicus. Improving nutritional intake. Offer a visually appealing and nutritious diet. Consult the child and the family to learn which foods are appealing to the child. Serving 6 small meals may help increase the child's total intake better. Promoting skin integrity. Inspect all skin surfaces regularly for breakdown. Turn and position the child every 2 hours. Protect skin surfaces from pressure by means of pillows and padding. Protect overlapping skin surfaces from rubbing by careful placement of cotton gauze. Bathe the child regularly, promoting energy conservation. Bed rest is common during the edema stage of the condition. Balance the activity with rest periods and encourage the child to rest when fatigued. Plan quiet, age-appropriate activities that interest the child. Preventing infection. Protect the child from anyone with an infection, staff, family, visitors, and other children. Hand washing and strict medical asepsis are essential, and observe for any early signs of infection.